to Keela.
Yeah, I was actually going to say, so today's case presentation is a little bit different than we would usually do. We actually, as you know, a planning group decided that it's probably best to hold off on a formal case presentation today and actually have more time to talk about just different methods people are using to still meet the needs of their patients, and also, you know, meet the needs that you need for your clinical practice during this time of social distancing. So that was really kind of the point of today's sessions, Eric. So you segued us into it very nicely, actually. So we did kind of come up with some guiding questions around the critical issue, and I can share that on screen. But really, again, wanted it to be more of an open dialogue in this session, so we can share kind of what everyone's doing, how workflows have changed, just really be here for each other. So obviously, our critical issue for the case today is how do we provide the needed level of treatment and support to our patients on MAT or with OUD, SUD while using the virtual telehealth model. And just a few guiding questions that we had come up with very quickly, but it's obviously there's more to talk about than just this. But really, have you been able to utilize the telehealth model and how's it been working? Have you had a lot of canceled appointments due to patients having children at home or other reasons? We know at this time, there's a lot of people with their children at home with them all day long, and that might not always have been the case for them. So that could be an extra stress on their life too. So just what additional support services are there for that? Have you canceled groups or are you meeting virtually instead? Have you noticed an impact on mental health status due to the isolation? And how are you helping patients feel less isolated, and what other concerns do you have? So again, it's not that you have to sit here answering a list of these questions. They were just guiding questions that we came up with to open the floor for some discussion today around what folks are doing. So I can turn it over to the spokes first if you want to share. I know we have Bucksport on, we have EHC, and a few others, St. Croix. Is there anyone that would like to share kind of the modifications you've made so far to accommodate this time of social distancing?
I can go. This is Lisa. I'm at the Down East Treatment Center. Yeah. We've kind of fine-tuned what we're doing. I'm still going to the office to do the groups via Zoom. And our administrative person is there with me, and of course we're more than 6 feet apart. But and our MAT provider is at home. So what we've been doing is we still have groups at the same time that we had them before, and the administrative assistant starts in the morning calling out to all the clients that are scheduled that day and scheduling a phone meeting with Linda, our MAT provider, and we're trying to work around the groups so people can still participate in the group. If people have an email address, they've been easily able to get in via Zoom. We have some people, for whatever reason, they're, either technology or they're using this as a time to not participate in group, whatever the reason. But I think we've got it down pretty well, and definitely the MAT part is working just fine. And the part about the urine drug screen, we're still asking folks to come in and screen. We're not, forcing the issue. We use Peaks Outcome, and they have a separate little area in the back of the treatment center. We have 2 really great collectors that are, still on board, and Peaks has come up with a protocol for keeping everyone's safe back there, and so that seems to be going well also.
Great, thank you for sharing.
You're welcome.
Others that would like to share what you're doing currently? Elaine, can you speak a little bit to how Maine General's kind of, or the Dartmouth Family Residency has taken, what approach you've taken to all of this? I know you've had a lot of different kind of creative workflow ideas and thoughts around this.
Sure, wasn't sure if we were still doing spokes, so I was just waiting to sort of jump
Yeah.
in.
Around.
I don't think any of us have the perfect answer. I mean, I think that's what it comes down to. I think it's balancing what you feel comfortable with versus, and I channel my inner Leah Bauer as often as I can, where, we were chatting one day and she said, geez, what changes your clinical management? And I think that's really the question I try to lead with. I'm a little different in that I care for a lot of high acuity patients, so patients that are, some that were sort of nearing the point of being transferred to methadone probably as this all started. So I feel some obligation to continue to monitor them just from a safety perspective. The other thing is I specialize in pregnant women. So I have a number of situations with moms who are home with very small children, with people who've lost their jobs. We know that people are stressed. I mean, I did probably 20 telephone visits yesterday. And I mean, I think the first 6 started with, I've been laid off, I'm trying to collect unemployment, I'm really stressed out. And we know that sort of kids are at risk in these situations. And so I'm trying to really just sort of balance everything, trying to keep people safe in terms of not putting them in the community, but also trying to understand what's going on to make sure that I'm keeping kids safe at home that might otherwise be at risk. So we're certainly bringing people in with some regularity. We also have a random drug screen line where our patients actually call a phone number twice a week to hear whether they have to come in. Everybody in our program is assigned to a state in the US. So if you hear Texas or Arkansas or whatever, you have to come in. And we've actually adapted the message there to call the office if patients have concerns about coming in or if they're sick, because we want to really just verify whether patients are kind of engaging in treatment as opposed to necessarily bringing them in. So that's sort of an adaptation that we've made. But, we're not bringing people in that are sick generally. We've had some situations where people are saying they're sick for now 4 weeks, and then it's like, how long do we keep them out of the clinic? I'm also work in a primary care practice, so it's a little bit different in that we have sick people coming into our primary care practice anyway. And we do saliva screens and are currently working with compliance around some type of system that would allow people to drive to our clinic and we could observe them doing their saliva screen through a window. So, I feel like you just have to sort of throw everything in the air and go, what works, and try to find something that works. But that also meets compliance and rules and regs at the hospital. But so it's a challenge, but I don't think it's a challenge that everybody's feeling the same thing. And but I do try to lead with the question of, does it change my management? Or, and I do one other thing, sorry, I'm a little long-winded here, but DHHS is basically the permanency caseworkers are working from home and not having the contact with these patients that they usually would. So there's a lot of structural systems that are typically in place that are not monitoring these patients as well as they would typically be. I have a good friend who's a probation officer. He's no longer going out and checking on patients or clients. So I think, we're sort of the last means of keeping people on track in some cases. And I'm also trying to support patients. I have a couple patients who insist upon continuing to come in the office because they feel that's what keeps them on track. And I'm certainly not going to tell them they can't come. So I just try to do the best I can in each individual case, but I don't think I have any better answers than anyone else has out there.
Thank you for sharing. What are others doing, or do people have kind of questions around this? I mean, now's time, we're all together. We have a lot of people attempting different workflows, different ways to still kind of, meet the needs. Are there other questions, thoughts that people would like to share?
This is Julian Kuffler from one of the things in trying at Downey's Treatment Center is increased use of recovery coaches because they have the ability to connect. As others have pointed out, everyone else is pulling back. And in some ways, now's the time to push forward, at least with phone conversations, and recovery coaches tend to make better connections than the rest of us. So I would just think about offering that to patients.
Similar to that, there's a lot of online meetings now that are Smart Recovery Online and other things. I can send a link that I have from In Alliance from Addiction Recovery. And that's been very helpful. They've actually seen more patients coming to that virtual setting than they typically did in the past.
Please send in that link.
I sure can. Yep, I absolutely can. I have it in my email.
Great, thank you for sending that. Abby, not to put you on the spot, but can you kind of chime in from your viewpoints?
Yeah, absolutely. You did say Abby, right?
Yes, sorry.
Great, thanks. So, a few things that really stand out to us and have been touched on a little bit here already is just concern for the increased risk that this vulnerable population is already experiencing, and around just the physical isolation. And we know that there's been an increase in access to online support meetings, and those are being shared and really generated. And I know a lot of our recovery resources have been sharing that information, but we see also a lot of barriers with some of the equity issues, particularly in Washington County and other rural parts of the state. Broadband is not available in all areas. Not all of our participants have smartphones, or they're managing children in the household that also need to be using technology at the same time. So we're trying to really support and find unique ways to reach those individuals, whether it's connecting via telephone, if that's an option for them. Also, of course, as Julian had shared, really partnering with and Healthy Acadia's work with the recovery coaches. A few things that have also just been kind of top of mind is the impact that this will have on individuals that are engaged in current substance use. There's a school of thought that this might be an increased opportunity for them to access treatment services in recovery if they find that engagement in substance use just has significant barriers right now. And so we want to ensure that services that are providing MAT, and if they are taking new patients on, that information is available to those that share information, whether it's 211 or within the community. I was recently on a call with the Alliance of Addiction and Mental Health and listened to many providers from across the state. And that was one of their concerns, was that there was an assumption that their programs weren't taking people in, or that they couldn't access new services. So we're really trying to share that broadly, that MAT providers, although they're moving to virtual platforms, they're still offering these services, and also really ensuring that harm reduction services are made widely available. I recently talked to a community member that's a volunteer for main access points providing naloxone, and she had indicated an increased ask for naloxone by both family members and individuals that were currently engaged in substance use. So as MAT providers, I know many of you in your practice regularly make that offer to clients or provide naloxone to clients, but just ensuring that is part of our protocol as well. As Eric had said, there's a real increase in fentanyl. We're seeing an increase in fentanyl usage, particularly as other heroin and other illicit substances are maybe harder to access at this time. And so those are a couple of pieces that I'm hearing both from the community, and we're really trying to highlight and push forward, is that services are still available. They're being accessed in different ways, trying to break down barriers for community members that want to access these services, and also ensuring harm reduction strategies are in place.
Great, thank you for sharing that.
Can I add one thing to that?
Yeah, definitely.
So the only other piece said that along the lines of harm reduction, our needle exchange has expanded hours, and we're able to offer more, so R being Main General. So if for anybody who's nearby or able to get here, it's expanded in both Augusta and Waterville, and we're offering things like food bags and other services through the needle exchange, so that can be a point of contact for people to get connected with some other services as well. We're seeing, anecdotally, that the price of drugs is going up on the streets, and there's sort of a lot of desperation right now, in addition to all the social factors that have already been mentioned.
Mm-hmm.
I'd just like to add in, as a primary care person in a private practice setting, I've actually gotten more calls recently from people that typically might have been calling groups or another organization and haven't heard back for whatever reason. So I think that there is an increase of individuals looking for treatment that might not have. And I'm able to get them in relatively quickly, although I'm not in my private practice because I'm doing some per diem work in the ER, but I am here every other day, so pretty quickly we can get them in. So that's been an interesting phenomenon for me to see, that more people are turning to smaller practice as opposed to one of the bigger organizations at this stage. Many of my patients are patients I've had for years, having done this as long and been in a couple different settings. And so I've backed way off on urine drug screening counts, stuff like that. I've probably increased more phone calls to them and probably have more contact with them than I typically would, given that I think they need more support. But in terms of people looking for intake availability or getting started in the program, there's been several, which has been heartening in some ways.
I might just have a quick reflection that I think it's really interesting, as the whole field of MAT has really moved to more supportive kind of treatment programming, that it has been really fascinating to see during this COVID-19 electronic medium era that we've actually pushed the envelope even further towards more risk or harm reduction approaches, meaning that we are spending a fair amount of time really supporting individuals, not necessarily doing the level of drug testing we were before, not necessarily stopping individuals who may have some other concerning use behavior. So it's actually fascinating. I wonder what it's going to be like when we resume back. I think that we will change. I mean, all of us are talking about how that our practice will probably change, but that we have been focusing a great deal on, some of the information from SIMSA as well as SIMSA coming out around, do we provide treatment, do we provide MAT service without a counseling component? And at this point, we've really pushed the envelope, and we're utilizing, in many ways, an advanced sort of harm reduction approach during this era. And I think that we're going to have a lot of learning from this. And it's very possible that we are going to come back and say, maybe some of the highly more rigid structured approaches that we had been using demonstrates that we can practice differently. And we have done quite a few changes, as a matter of fact, in regard to that. So I think it'll be really, really very interesting. In terms of drug testing, some very creative things I think are occurring, which is very interesting. I think that the more that we can use testing as a treatment aid support, and less of an enforcement arm, and that's what's causing this to happen at this point. It's actually allowing us to have a philosophical shift as we're in this era. And I think if we can sort of stop and collect some of our own data as we're going through this and do a comparison with practices before and seeing what learnings we have from it. And I do think we're going to learn a variety of things from this. So yeah, just a general reflection.
That was a great reflection. And I completely 100% agree. It'll be interesting to see what the permanent changes are after all of this. I mean, I know there will be some things that go back in place. You know, just emergency rules will change. Certain methods will go back, but it'll be interesting to see the long-term effects of all of this. And it really pushed us as a state to finally launch into telehealth, which we've been a little bit behind in for years. So it was a push that was much needed. It's just unfortunate that all the infrastructure wasn't in place and ready to go for that. What other thoughts and questions do people have? Have you run into any scenarios where you're looking for some help with, you weren't really sure how to handle it? Anything that kind of came up? You can also type into chat as well.
I have a question
Mm-hmm.
for everybody. I had one individual who was released from jail early. Perfect. I think that was very reasonable. But came out saying, you know, he didn't have any medicine. He was told to deal with it later. And I was happy to, I mean, I knew him well. I think he needs a higher level of care than I can provide, but I'm happy to get him through this time. Again, risk reduction, I think he's doing pretty well. From what I can tell, I do check in with him weekly. He's not somebody I've given a long leash, but again, it's all by either FaceTime or telephone. Is anybody else seeing that, especially the jail population? Is anybody, where are most of these folks going that are being released early?
Is this Kennebec County Jail?
Yes.
Yeah, so I can speak to that a little bit, unless anybody else wants to. So we're working on that. I didn't understand, and maybe this is helpful for other people who equally, it's kind of a black box for me, but I take care of a lot of people, obviously, who are in the jail. So as I understand, ENTO, which has the contract to provide the MAT at the jail, actually only has the contract where they provide the initiation for people who are not in treatment when they enter jail, which I thought they followed everyone. I didn't understand that. And then they arrange for follow-up when those clients are discharged. If the patient is on MAT when they get arrested or sentenced and they meet whatever the criteria is in the jail, which does change a little bit over time, then the jail medical staff actually continues them on buprenorphine, not to ENTO. And I think the challenge I've looped Gordon and Lisa and a couple other folks into this, some folks from SAMS, and I think what's not happening is that contact from the jail medical staff to external prescribers, in which case sometimes was us, but we don't have any knowledge that they're getting released at all, early or otherwise. And then there's a few people that have been released back to a prescriber that's no longer there, as I understand. So that's been a separate challenge. But the patients it's not being well communicated to the clients. And so they're going to the pharmacy when they get released from jail expecting to pick up a script, and that's not happening. So no, there's a large group of us behind the scenes trying to make this better. So we've had a couple people in super high risk situations that just sort of landed with us, and we're trying to keep them out of the ED, obviously, for the ED inductions. We're trying to not do that. but they've kind of floundered. And we actually had one person stay in jail over the weekend because she knew she was super high risk. And she chose to get out on Monday and then reported to our office about an hour later because she knew she was super high risk, which in some of these sort of beautiful moments, right, that these people identify what they need, and knew she probably wasn't gonna be able to find Suboxone outside, so stayed in jail over the weekend. So anyway, which is not what we want them to do, but we're working on it. And I didn't understand the nuance of the ENSO versus the jail medical staff, so I may not be the only one that didn't understand that. But it does need to get better, and I'm trying to work with the right people to make sure that collaboration happens in a more robust way. To be continued.
Yeah, that's great. That's actually very helpful. And I trusted that. I felt like I had to trust that he was telling me the truth. And I really believed that, again, risk reduction was the better option. And so I've been giving him a week at a time, and I'm very comfortable with that. Depending on where we end up down the road in terms of, and he's doing really well right now. So I think part of it is that it's not as accessible on the street right now.
Well, and I think I think part of this was exacerbated by the fact that a bunch of people got released early. So I think there was a bit of that. But I think it also just needs to improve overall. And I'm the scary part for me is that, people who don't know you exist or I exist or any of these other things, they just get let out into this wherever. And particularly if their prescriber is no longer there, which again is apparently in practice in Augusta. That's a super scary situation for a patient to find themselves in. And I do think there is a perception, as to your point, Jen, that, these practices are open to new patients, but patients don't perceive that. And I think it's because no one's there or no one's at the door or, things are dark. And so I think we need to continue to figure out a way. We've been trying to have staff at our office every day, and we have to make all the phone calls from the office, and that's the rules, at least at my place. So, there's a perception that we're open, and I think we need to figure out how to have that perception be the same for some of these places that are completely online, that looked closed if you were to just drive by. So.
Just to kind of add to that, Elaine, a little bit, I know that there's no one perfect way to get all of the messaging out, and really there's been a lot of discussion around trying to ensure that a lot of the information is kind of mobilized and reported to one place to be able to distribute it, because we see a lot of organizations respond in a way to want to make up resource lists and get all this information out. And I know we as a physician, and so we've really pulled our partners to say, how can we do this together so we're not all duplicating work? And I recognize, again, that there's no perfection in all of it, but I do know that 211 is really encouraging organizations to check in with them if they're not on their list. Make sure that you get on their list, because they're trying to really be that central hub. And we recognize that the governor's office and the CDC is pushing and all of our community members to reach out to 211. So that might be one of those areas that we can just, as organizations, reach out to make sure that we're listed there. And if we're not, to get on that list.
Yeah, I want to add, thank you, Abby. Abby and I have been in some of those conversations together, and we're still in those conversations about what's the message and what's the best way to get a message out. And we were talking internally, and so I'm curious about the folks on this call and what your answer might be to this question of what's the message. And Elsie Flemings, our executive director, and I were talking about this yesterday. I think the message might be just as simple as help is still available, call first. Everybody's open, just call first, so that it's not a big long message about each individual spoke or site, but that it's one sort of simple, help is available, help is still available. So I'm just curious what people think about what the message should be.
I think from my perspective, I really like that message a lot.
And I wonder if there's a role for community pharmacists to help support that message. So I think about maybe people that go to the pharmacy and buy over-the-counter loperamide to sort of self-treat withdrawal symptoms. That might be an opportunity to sort of engage people and let them know help is still available, or if there's a way that community pharmacy can somehow be part of that conversation.
Yeah, I mean, I agree with that completely. I remember asking my pregnant women, like, if I were to, you know, how would we find you? Like, if we wanted to get you into treatment earlier in the course of your pregnancy, and they were really clear, like pharmacies, supermarkets, Hannaford, Walmart, big box stores, and you know, somehow in the bathroom or near the bathroom or in that area was, they were like, that's where we will find it. So it's kind of on Stephanie's point.
Other thoughts on the messaging? Penny, I think that's probably the easiest way to go, and it's really just getting the major theme out there that there are still services available and we can help. Just call your specific area first. But other thoughts from people?
I'll bring this to the clinical advisory. Sorry if I cut somebody off. I'll bring it to the clinical advisory committee. We're meeting again this Thursday because of the acuity of the situation going on. Gordon's opioid response clinical advisory committee, and I'll try to see if we can wrestle this idea into sort of a smaller messaging type thing, because I love the simplicity of it, and I think that's just what we need to do. But if there's some kind of way that we could communicate it through all the MAT providers, that would be great.
Well, and I would say from the Down East Treatment Center that most of the folks that come in there, they all know each other, and they know people that are still out in the community and that aren't getting treatment. And so I guess to reinforce the notion to the people that are coming there already that, you know, we're still taking people in, we're still doing intakes, so that they can share that with people that, you know, might be seeking treatment.
That's a great thought. I love that idea, the messaging, and as you had said, Lisa, around getting the message out to the community because they share that information. And I would say on the other side of that, if there's any challenges with them accessing, just like you were saying, Jennifer, they've maybe called and they haven't gotten a response, that message also gets carried into the community. And that's where some of the assumptions are made that services are shut down. So we just want to make sure whoever's taking those calls, who are the ones answering those emails on the front lines, that messaging is consistent, or the message in the community among the community members will be, well, I called and I haven't heard back. So I think we're all kind of working on that in our organizations.
You may have reviewed this since I had to join late, but I know that we at the DTC have experienced an increase, and I've heard groups has, and I'm not sure about some of the other providers. And we were at a meeting with Gordon just this past week and talked about a variety of the theories behind it, and I think some of it has popped into earlier where access to street drugs is becoming a little more limited or a little harder to get, and potentially some who are in withdrawals trying to get access to MAT services. I'm just trying to get a sense of what it's like in the area, and are we seeing an increased requests in the past few weeks, and are consumers identifying why they're coming in? We kind of checked that they were increasing, but they weren't saying why. I guess I'm not going to come in and say my supplier is not as available, but just want to get a pulse of, are we seeing an increase in requests? And are any of the brave clients able to talk about why they're coming in at this point?
I mean, I think, yes, we're seeing an increase in requests. I've been trying to get information. Sometimes I have the folks at the needle exchange ask it because it's easier for them to ask than me, because for obvious reasons. But prices are going up is what I also understand. So there's sort of a supply issue. I don't know about quantities. I don't get into that. But I think also the sort of social way in which people acquired substances is obviously significantly reduced.
Yep.
And so I think there's sort of lots of variables, and kind of not wanting to be in sort of this desperate place where you have to go out and go to multiple different places and to acquire maybe a day's worth as opposed to entering treatment. So I think there's a lot of variables at play, but I definitely get the perception that it's harder to come by, and also harder to come by so both our patients have less income, right, because they've gotten laid off from their jobs, or they're collecting unemployment, which is a third of what it was or what they're reporting to me, and then also the prices are going up. So there's just a complete desperation all around.
Right. And one of the other, thank you, that's very helpful. One of the other reflections are that for people who have access on and off, they usually will buy street Suboxone to manage withdrawals. Well, part of the theory is that that avenue is getting more limited, so the street Suboxone is potentially not as easily accessible as well. So now you both have the actual drug as well as the street, and so potentially bringing people in. But glad to hear that there's an increase, and that's a good thing. Not that we want to see the challenges they're experiencing, the users are experiencing, but if we can be there to support them, this is probably a great opportunity to really provide highly supportive care of which they might be willing to stay with it. Yeah. Thank you. Just curious if we were seeing it elsewhere, but thanks.
Other questions or thoughts for each other? We still have a few more minutes. A lot of you have mentioned kind of an increase in the calls coming in, maybe looking for treatment services. But have any of you noticed with current patients if it seems like you're not hearing from some of them more, or do you have any concerns about patients that are currently kind of in your panel that you haven't heard from, you've been trying to check in with?
I don't know if people have it. My patients have changing phone numbers or no minutes on their phones, but also they live in such rural areas that it's like my staff will try to get in touch with them, and then they'll finally call back 2 hours later and be like, okay, if she calls at this time, and I put the phone, on the top of the second window of my second bedroom. I mean, it's like the service is so bad that it's all the limiting factors. That's really stressful for people. It's less about the kids running around at home, because usually they bring the kids with them anyway, so they're just running around my office. But it's sort of the the remoteness, right? I mean, my cell phone doesn't work at my own house. Sometimes my pager doesn't even go off. So it's the remoteness, I think, kind of really multiplied in this situation as well.
I would agree with that. I think so. We're seeing, some people just don't have internet access, phone access. They have less money now because the ones that were working have been laid off, and they're desperately trying to apply for unemployment, and that's yay or nay. You've got kids home that wouldn't necessarily be home, although a lot of times that also means older kids are home to watch the younger kids. Transportation issues, you don't have KV cap, you don't have, again, transportation is always an issue. Now it's an even bigger issue. So it feels like to me it's just this perfect storm. But in general, I'd have to say that, again, a lot of my people are been with me for a long time, but even some of the newer ones and some of the more tenuous ones that I've had more concern about over the last few months seem to be hanging in there. It's almost like they know that the alternative of turning back to using some sort of opiate or street drug has a whole new level of danger to it, and is that much harder to get. So even though there's this perfect storm of more barriers, I think they seem to be hanging in there for the most part.
I have found that I have a couple of people that were sort of, on the fence with their treatment, kind of teetering there, and they kind of go, right now they're going in and out. They'll disappear for a few days, and part of it is that we're not requiring them to do urine drug screens. We're not requiring them to show up for group. They participate by phone, and they can sort of do that selectively. And also the transportation issue. And, I can think of one person in particular that I know he is not supposed to be driving, and he was driving anyway, but now there's kind of more of a eye on those that aren't supposed to be driving. And so kind of all of those factors. But we still try, we still call and leave messages, and we're still here.
Great, thank you. So we are nearing the end of our time. We probably have a few more minutes for any final thoughts from folks. Also, if you do come up with a question, obviously we're always available to try to help answer. So even if it's like a week down the road, something happens, a specific scenario that you need help with, certainly we're helping. Caroline and Penny would probably echo that.
Yeah, I'll just add, I just wanted to invite Caroline or Lisa or Linda or some combination to just briefly describe the system where coaches are calling folks on request without entering full coaching relationships with them. Caroline, do you want to do that?
So, right, Julian, you had mentioned that now is the time to increase use of recovery coaches, and absolutely, that's imperative. In addition to that, an initiative we've got going at the DTC is for those folks who are isolated, which is a lot of people, obviously, and could use a check-in call. It happens to be a recovery coach doing the check-in calls, but this is different than a formalized recovery coach relationship. It's somebody picking up the phone and saying, how are you doing today? What's going on? And that just gives that individual a sense that they're not alone. So I urge all of you guys, it doesn't have to be a recovery coach. If there's a staff member that can take 15 minutes of his or her time simply to make human connection, that is very, very powerful. And who knows, maybe it could prevent somebody from doing something we wouldn't want them to do. So.
And I would add to that, because of the technology challenges that a lot of our folks are having, that, if a recovery coach calls somebody and they don't answer, they might not hear the phone. They may be blowing you off, but they might not hear the phone. And so maybe, give them a couple of chances. I know we have one elderly lady that she doesn't hear the phone half the time. So, but she would really benefit from a conversation. She would love that.
Yeah, and even to get that voice message that says, hey, we're trying to reach you, just want to see how you are. That could mean a lot. So.
Yeah, and I'm not sure she has voicemail on her phone. So I think we just have to try and try again.
Yeah.
Great. Well, as I said, there will be more questions that arise as we go through some of this, and just as time happens, situations will occur where you might need extra support. So certainly feel free to reach out if you do find that your practice or yourself needs some extra support during this. Caroline, I'm going to turn it over to you to kind of summarize. It's not typical notes, it's more of, the different things folks are doing that people can take away and see if it would also work in your clinical setting.
Sure. So some of the meat of this conversation was, like we were just saying, to reduce isolation. And that can be done with brief check-in calls. It can be done by enhancing the use of recovery coaches. And it can also be done by having online meetings where people can have a sense of connection via whatever platform that is, Zoom, Ring Central. Also, there was discussion about barriers. So it's important that we recognize what are the barriers folks are facing that might not enable them to continue treatment. If it, for example, Abby was making mention that bandwidth might be a problem, especially if your children are using bandwidth for school. So maybe providers and staff can come up with ways to knock down those barriers for patients. Another key point was the impact this is having on folks who are actively using. This might be an increased opportunity for those folks to access treatment. And as a result, this is important. It's important that we have information available that's reliable. So for 211, we got to get on 211's list, make sure that our organization is listed so that people know we're around to help. The messaging, to Penny's point, messaging is extremely important. Again, letting people know we are around to help. And something that Clem brought up, which I think was extremely important, is how is this going to affect all of us in the future? The world is changing, and this is really a philosophical shift. So now might be the opportunity to collect data to figure out, well, this is working really well. Maybe we want to implement this in the future. So that's kind of the meat of it. I know we talked about urine drug screens, saliva screens, but I feel that those are the big points.
Great, thank you for summarizing that.
All right, I just have two administrative things, Kayla. Sorry to yet. So put your name in chat if you've joined and haven't done that. That's really helpful because we keep attendance and we like to know who's joining. Also, I'm going to put the link to this survey. If you need a CME, please just cut and paste this and put it in your browser, and then you can get your CME. Otherwise, you may not receive CME for this if you don't click on it. So I'll send it right now.
Great, thank you. So we are nearing the close of today's session. I want to thank everyone for kind of taking a pause with us and going in a different direction for today, just so we could talk through some of these issues and make sure that people had a chance to kind of bounce ideas off of each other. Next month we will resume as normal with the case presentation is the plan at this point, and hopefully it'll be a little bit calmer by next month's session, which is on May 13th. I want to thank Eric for doing our didactic today. That was helpful and a great segue into the current times as well, very timely, so thank you for doing that. But otherwise, I think folks are good to go. Caroline, did you have any other closing announcements?
No, everybody just stay safe.
Yep. And if faculty can stay on, that would be great.
Yes, faculty stay on. I hope everyone else has a great afternoon. Stay safe.
Stay safe. Stay healthy.
Mm-hmm.
I think we have some students who are joining just to see, but I think we're.
Did we lose them? Okay. All right. So I know that was probably not a traditional echo session, but we did feel like, you know, given everything going on, it was time to step back and just let folks either have questions or not, or be quiet and listen. But I just want to thank you all for kind of stepping up and providing information on what you're doing. There's a lot of adaptations and workflows and just different protocols at this point. So it was great to hear from all of you and get your input.